Hello. This presentation was created by Dr. Donald Juravich, a professor of geriatrics at the University of North Dakota. Today, we have a presentation on prevention in older adults. This is a project through the Dakota Geriatrics Program, which is a federally funded HRSA program called the Geriatric Workforce Enhancement Program. The objectives for today are to first align preventive services with older adults' remaining life expectancy, as well as consider their cognitive status. We also want to talk about how to apply the annual wellness exam enhanced with geriatric assessment. Some topics covered include cancer screening, other preventive measures, lifestyle counseling, geriatric syndromes, immunizations, recommendations for chemoprophylaxis, and finally, the annual wellness exam. Various artists will be included in this talk, and we may make comments periodically in relationship to each slide. This particular painting is a self-portrait by Grandma Moses, a Vermont painter who started painting when she was 76 years of age and lived to be 101. Prevention needs to be guided by remaining life expectancy of the older adult. Generally, we use most of the screening measures for individuals who have greater than 10 years of remaining life expectancy. Although we need to consider highly functional individuals who may have less remaining life expectancy, we also need to consider excluding preventive measures for those individuals that have moderate to severe dementia. Furthermore, functional status is always important in considering preventive measures, particularly if there's advanced functional impairment. Of course, if somebody has 6 months to 1 year of life remaining, appropriate for hospice or palliative care, those individuals too would be excluded from preventive measures. It's important to have our prevention efforts align with what matters to the older adult. We want to consider not only the length of lifespan, but also quality of life. The whole goal is to really maintain functional independence. The goal for cancer screening is to identify cancer in order to prevent morbidity and mortality. We need to balance that with the cancer screening. The harms, which include anxiety, complications, false reassurances from false negatives, and also overdiagnosis, where discovery of a tumor may not really impact the lifespan. This is certainly seen in prostate cancer with older men. Why even do cancer screening in older adults? The answer simply is for colon cancer screening. The incidence increases with increasing age. You can see the information here most recently from 2020, where the rate per 100,000 population basically goes up exponentially. At the end of the bar graph, those 85 and older have the highest incidence of colon cancer. The good news is that colonoscopy, which is recommended every 10 years without any associated complications, results in a lower incidence rate of colon cancer. You can see how things have progressed over the last couple of decades, where the incidence rate of cancer has gone down considerably by the increased use of colonoscopy. Building on our discussion of colorectal screening, the NCCN updated their guidelines in 2025 to include blood-based tests like the Shield ctDNA as a less invasive alternative every 3 years for average-risk adults starting at 45. The ECLIPSE study shows about 83% sensitivity for detecting colorectal cancer signals in the blood. But remember, a positive result still means following up with a colonoscopy. For our older patients, this could be a good fit in the 76 to 85 range if they're otherwise healthy, but we skip it over 85 since the benefits don't outweigh the remaining life expectancy. What are the screening tests for colorectal cancer? Notice the recommendations for 50 to 75-year-olds. The fecal blood test every 5 years would be one recommendation. Colonoscopy, CAT scan, colonography, or flexible sigmoidoscopy would be all reasonable interventions or assessments. In the 76 to 85-year-old group, the idea of testing through any of those measures mentioned above for the 50 to 75-year-old need to be taken in accordance with what the patient's overall function and health status may be. In individuals over the age of 85 years old, no colon cancer screening is recommended simply because the remaining life expectancy would not be there to justify further cancer screening. Now it's time for our first polling question. For average-risk adults, what is the upper age limit where colorectal cancer screening is generally not recommended due to limited life expectancy benefits? A. 75 years. B. 85 years. C. 95 years. D. No upper limit if healthy. The correct answer is B. 85 years. This is based on guidelines individualizing for those aged 76 to 85 and stopping when more than 85 years of age. What about breast cancer screening? It's important to discuss mammography at least every 2 years if there's greater than 10 years life expectancy in older women. The average life expectancy for women is 81 years of age. There's no evidence that mammography improves survival in individuals over the age of 75. When we look at the impact of clinical and self-breast examination, there's not a lot of good data to support either. However, it is generally recommended that a clinical breast exam be done as part of an annual physical exam. The 2024 USPSTF Breast Cancer Update reaffirms there's insufficient evidence, graded as 1, for routine mammography in women 75 and older. No randomized controlled trials focused on this group, and computer models indicate only limited survival benefits. That said, it's worth discussing biennial screening up to age 74 for those with more than 10 years of expected life, always tying back to what matters most to the patient, like quality of life. With cervical cancer screening, the recommendations are to have Pap smears every 3 years. If you combine it with HPV testing, that would be done every 5 years. You can stop after the age of 65 for women that have had 3 consecutive negative cytologies by Pap smear or 2 negative papillomavirus screenings prior to the age of 65. This discontinuation of Pap smears can be done regardless of the sexual history or new sexual partners that might be associated late in life. Prostate cancer screening is not recommended for men over the age of 70. It would be good to discuss the prostatic SIR antigen with what we call the young old, those that are between the ages of 65 and 70. It's important to point out that 80% of positive PSAs may come back as false positives when you have a fairly low threshold of 2.5 to 4 micrograms per liter. With lung cancer screening, it's now recommended that low-dose computed tomography be done in 55 to 80-year-olds who have had a 30-pack a year smoking history and currently smoke or have quit within the past 15 years. The level of evidence for that is quite good. Its level in terms of stop screening would be individuals who have not smoked for 15 years. The other aspect is if the surgical intervention wouldn't really improve life expectancy, or they have low functional status. Those would all be indications for not screening any further. Another indication is if the patient doesn't want any further additional screening because they wouldn't have surgery anyway. The United States Preventive Task Force indicates that there's insufficient evidence to recommend things such as a whole-body skin exam. If a dermatologist does it, maybe a little bit better screening for cancer of the oral cavity, urinary tract, bladder, or thyroid is not indicated as a routine measure. For ovarian cancer, there's no recommendation for screening for cancer antigens, ultrasound, or pelvic examination. Older adult women that may complain of bloating or fullness, that could be one of the signs of ovarian cancer. Based upon symptomatology, it may be important to follow up with some of these tests. However, just as a routine screen, it's not recommended, and again, no screening pelvic examinations in asymptomatic women. With asymptomatic older adults, bacteriuria should not be tested with urine analyses. A symptomatic individual should not get Kate duplex ultrasonography. There's no point for screening hyperlipidemia with LDL if they're completely healthy. It's not necessary to do treadmill exercise testing if there's no history or symptoms of coronary artery disease. The other aspect of screening for or against the asymptomatic older adult, glaucoma should not be routinely screened. Although glaucoma screening is part of the Welcome to Medicare exam, Medicare does pay for it, but there's no evidence that spirometry tracking of COPD makes any difference in health outcomes. Healthy individuals who do not complain of symptoms of obstructive sleep apnea don't warrant a sleep study or routine screening for osteoporosis. It's not really recommended unless there's risk factors. For peripheral vascular disease, routine use of ankle brachial index is not recommended. Generally, if you can't feel pulses, then that would be an indication that there is a sign of arterial insufficiency, and that certainly would warrant an ABI request. For thyroid cancer, there's no evidence that palpation really improves the detection of thyroid cancer. However, it is very important to have a neck exam. For hypertension screening, it's recommended that it be done. However, if the blood pressure is elevated, it needs to be confirmed in the home setting. It's important to have a home blood pressure cuff measured or calibrated with the clinic, so that the individual will know that usually they're automated blood pressure cuffs. You want to have a correlation to make sure of what they're testing, but generally, most studies show that home-based blood pressure measurements are about 10 millimeters of systolic mercury lower than what you find in the clinic. Whether you want to call that white coat hypertension or otherwise, the studies are pretty confirmatory that there is a major difference between clinical measurement and home-based measurement of blood pressure. Here's a painting by Diego Rivera of the larger BMI individual. It's typical in older adult healthcare that's predisposed to type 2 diabetes or prediabetes. The American Diabetes Association recommends screening all adults over the age of 45 with either a fasting blood sugar hemoglobin, a once or a glucose tolerance test. The United States Preventive Task Force recommends screening older adults between the ages of 40 and 70 who are overweight or obese, a little bit more refinement in one case. It's brought both of these groups' recommendations just to show that there are some small variations with each different kind of screening recommendation. We always have to keep those in mind. With aortic aneurysm, it's a one-time screening for men over the age of 65 who've ever smoked, whereas there's equivocal evidence for selective screening of aortic aneurysms in men who have never smoked. For women, it's not so much recommended. Diego Rivera was the significant other of Frida Kahlo. Frida Kahlo always had a lot of her paintings with hearts and arterial systems, connecting the lighter side on the left and the darker side of her personality on the right. For osteoporosis screening, all 65-year-old women and younger who are at high risk should be screened. A DEXA scan should be considered for men, particularly those over the age of 80.